All right, pharmacist interventions part 9. What I like to do is give patients their Depo-Provera, which is the injectable hydroxyprogesterone. It's intramuscular. It's given every 3 months. There's a sub-Q version, but most patients get IM. This medication has a black box warning for bone mineral density loss past 2 years of usage for long-term usage. So I had a patient who I was giving injections to, and she told me she was on it for 5 years. I told her to talk to her doctor about that because of that black box warning. So I do give a lot of patients their depots. Most of them are in their 20s. Another intervention I had is a patient who was like 20, 21. She was given it's either Xanax or like Klonopin, but it was some sort of benzo, and it was scheduled like for twice a day. It was like 60 tablets for a month. And I intervened and counseled, and I was like, hey, have you ever been on this before? And she said, no, this is my first time. So I had the benzo counsel with her. I told her about how it's inappropriate to schedule a benzo for long-term usage. It's not recommended in anxiety guidelines to initiate it like that. I had the discussion about as needed or PRN usage when transitioning on to something like an SSRI. And then I talked about like maybe with panic disorder, you want to use it also sparingly, maybe a few times a month. You don't want to get scheduled on it due to that tolerance, dependency, and then also poor long-term symptom management with anxiety. So I had that intervention with her. I don't usually see a lot of patients like at the very, very beginning when they start taking it. So that was a interesting conversation with her. She was very receptive to what I was saying with her, or what I was saying. Another intervention I made was a patient who had like moderate, I would say, asthma. And she was prescribed carvedilol, which is a non-selective beta blocker. Non-selective beta blockers are known to increase risk for asthma exacerbations. So when you're treating someone who has asthma for some sort of either cardiac condition or second line as a hypertensive agent or blood pressure agent, maybe someone has AFib or heart failure, you want to use it first line, and if they have concomitant hypertension. So carvedilol, I guess, is a good choice for blood pressure because it has that dual mechanism with alpha blockade and beta blocking activity. But in this situation, she would have more so benefited on a selective beta blocker, like metoprolol is what I recommended. But the selective beta blockers are acebutolol, atenolol, bismolol, metaxolol, metoprolol, esmolol, and nebivolol. Nebivolol is the generic of Bistolic, which is what patients are used to calling it since it just went generic within the last year or two. But that's kind of what I recommended with her. I didn't want her to have an asthma exacerbation. Okay.